Welcome back to the Deep Dive. Our mission, as always, is to take these incredibly dense medical, scientific, or financial sources, the ones that feel like homework, and really filter them down.
Filter them into something that's genuinely useful, concise, and most importantly, something you can deeply understand.
And today, we are tackling a chemical that is, it's a clinical miracle for millions of people.
Well, absolutely. But it's also a pharmacological tightrope walk for any doctor prescribing it. We're talking about methylphenidate.
You probably know it by its most famous brand name, Ritalin, though there are many, many others.
And this is not going to be a simple surface-level look.
No. To really get our heads around the true safety profile of this incredibly common medication, we've basically assembled a virtual medical consortium.
Yeah, we've pulled the core insights from 6 really distinct expert authorities. We're looking at the pharmacology from Micromedex, the big picture clinical context from Harrison's principles,
And then the really stark cardiac warnings from the European Heart Failure Society.
the EHFS, exactly. And we're rounding it all out with the very latest clinical guidance from UpToDate 2025. The goal here is to synthesize this consensus of caution.
Right. Give you a comprehensive, evidence-based risk assessment that, goes way beyond what you'd find on a basic patient insert.
And when you stack all these sources together, they paint a really compelling picture. This is a profoundly effective drug, no question.
Good.
But its inherent mechanism, how it works, demands this extraordinary, continuous clinical vigilance. From the very first dose through every single year of treatment, you just can't treat this drug lightly.
It sounds like the details of how you administer it are just as critical as the drug itself.
They absolutely are.
Okay, let's unpack all this. Our starting point, and really the central question for this first part of our discussion, is pretty foundational.
Let's lay the groundwork.
Exactly. Provide a complete overview of Ritalin. What is it? What's its core mechanism? Why are the starting doses and formulations so complex? And what do our experts say are the most important cardiac risks and systemic interactions we absolutely need to be aware of? So let's start with the absolute basics of what this drug actually is on a molecular level.
Right. Micromedex defines methylphenidate as a central nervous system stimulant, a CNS stimulant.
Okay. And it gets more specific, right? It calls it a piperine derivative stimulant.
It does, which sounds incredibly technical.
It really does. So what's the actual engine here? What's driving its effectiveness, and why does that classification, piperine, even matter for us?
What's fascinating is how it achieves these powerful focusing and alerting effects. It's, pharmacologically speaking, a very direct method.
Okay.
You can think of it as just manipulating the brain's internal messaging system. Its primary job is to act as a mild CNS stimulant by blocking the reuptake of 2 critical neurotransmitters.
That's norepinephrine and dopamine, NE and DA.
Exactly, norepinephrine and dopamine.
So blocking the reuptake. If I remember right, neurotransmitters are the little messengers sent between brain cells, but then they normally get recycled, sort of vacuumed back up by the cell that sent them.
That is a perfect analogy. And methylphenidate essentially jams that vacuum cleaner. It clogs up the transporter proteins specifically for dopamine and norepinephrine. And by preventing them from being sucked back into that first neuron, the presynaptic neuron, it effectively increases their concentration.
So they hang around longer in that little gap between the cells.
Right, the synaptic cleft. Their residence time is longer, their concentration is higher, which means the next neuron gets a stronger, clearer, and more sustained signal. You're basically turning up the volume on things like alertness, focus, and motivation.
So it's not creating a new signal, it's just amplifying the brain's own signals that are already there.
Precisely.
And this fundamental mechanism, this jamming the vacuum, leads us straight to a really stark warning from Harrison's principles of internal medicine. Harrison's does not mince words about where this drug sits in the pharmacological world.
This is maybe the most jarring piece of context in our entire source stack. Harrison's actually classifies prescribed psychostimulants, including methylphenidate, right alongside illicit psychostimulants like cocaine and methamphetamine.
Wow. Why? What's the connection?
Because they all share that same core mechanism. They all act on those dopamine transporters. Now, the kinetics are vastly different: how fast the drug hits, how powerfully it acts, how long it lasts.
Of course.
But the underlying biological target is related.
That family connection, putting a drug prescribed to millions of kids in the same category as cocaine, that's got to be unsettling for a lot of listeners. How do doctors even begin to manage that level of inherent risk?
It just means you have to have an intense respect for the drug's power and its potential for misuse. That pharmacology pharmacological identity is why it's only approved for very specific uses in the U.S.
Mainly ADHD in patients 6 and older and narcolepsy.
Right. And it's why it carries the most serious caution the FDA can issue, the black box warning.
Let's zero in on that. What are the specific dangers that Lexicomp and the manufacturers say have to be highlighted in that black box?
Lexicomp is very clear. It emphasizes that the drug has a high potential for abuse, misuse, and dependence.
And what does misuse look like in this context?
It could be taking higher doses than prescribed, or, much more dangerously, using unapproved routes, crushing and snorting it, or dissolving and injecting it.
Bypassing all the controlled release mechanisms built into the pill.
Completely bypassing them. And the consequence of that misuse can be catastrophic.
You mean substance use disorder, overdose?
Yes. Severe substance use disorder, acute overdose, and death. And the FDA updated this boxed warning in 2023 to be even more specific.
What do they add?
They now underscore that providers must assess a patient's risk of abuse before they even write the first prescription. And they have to monitor them continuously throughout therapy for any signs of misuse.
So it's not a one-and-done assessment?
Not at all. And another key point they added is that most people who misuse prescription stimulants get them from family or friends.
So the education piece is huge.
It's critical. The clinician has to provide explicit education that these medications should never, ever be shared. The stakes are just too high for everyone involved.
The danger isn't just for the patient then. It's for their entire household, their environment. This continuous risk assessment, it's non-negotiable simply because of the drug's powerful relationship with the brain's reward system.
And that moves us from the why to the how.
Sure.
From mechanism to administration. And this is where the complexity just explodes.
All because of the delivery science.
Entirely. Lexicomp highlights a rule that really every single clinician and patient should have memorized. And that is, many methylphenidate products are not bioequivalent and are not interchangeable on a milligram per milligram basis.
Wait, hold on. If they all contain methylphenidate, why wouldn't they be interchangeable? If I'm on 20 milligrams of brand A, shouldn't I be able to switch to 20 milligrams of brand B?
You'd think so, but no. Not with this class of drugs. The difference is all in the pharmacokinetics.
How the drug is absorbed and released over time.
Exactly. Some are immediate release, they hit fast and they fade fast. Others use these incredibly complex delivery systems, osmotic pumps, bead technology, multi-layer cores.
To simulate multiple doses over a long period.
Right, over 8, 12, even 16 hours. So 20 milligrams of an extended release product is delivered in a completely different way than 20 milligrams of an immediate release one. They're not clinically equivalent at all.
So you have to individualize the dosage for every single patient every single time they switch products.
You must.
Okay, let's start with the simplest form then. The immediate release, or IR, products. The conventional tablets or solutions like Ritalin or Methylphenidate. What are the usual parameters there?
For IR, the usual starting total daily dose for kids 6 and up and for adults is somewhere in the range of 20 to 30 milligrams.
And that's split up throughout the day.
Administered in 2 or 3 divided doses. And the max recommended daily dose is generally 60 milligrams.
And the timing here is critical. This isn't just about convenience.
Oh, it's absolutely crucial. First, IR products have to be taken 30 to 45 minutes before meals.
Why is that?
If you take it with food, absorption gets delayed and can even be reduced, which compromises how well it works. And second, to avoid the most common side effect, insomnia, the last dose of the day has to be taken strictly before 6:00 p.m.
To maximize the effect during the day and minimize sleep disruption at night.
That's the goal.
Okay, now contrast that with the extended release, or ER formulations. They offer that once-a-day convenience, but they rely on these really complex physical mechanisms.
Right, take Concerta. It uses a sophisticated osmotic delivery system. It's a tri-layer core tablet.
An osmotic pump in a pill.
It really is. It releases an initial dose right away and then slowly pushes out the rest of the drug over many hours. For a naive patient, 6 or older, the typical starting dose is just 18 milligrams once a day in the morning.
And Ritalin LA.
Ritalin LA uses beads that dissolve at different rates. That one typically starts at 20 milligrams once daily. And while the standard max for most of these is 60 milligrams a day, Lexicomp does note a specific exception for Ritalin LA.
What's that?
For some heavier patients, over 50 kilograms, they may actually require and tolerate up to 100 milligrams a day. But that requires significantly more frequent monitoring. You're going way off the standard reservation at that point.
This brings us to a really unique and frankly alarming part of this whole discussion.
Yeah.
The mechanical and safety warnings that are specific to the formulation itself.
The physical pill or patch, not just the drug's chemistry.
Exactly. Let's start with that Concerta-type osmotic tablet. What's the risk there?
This is a profound warning that really shifts the conversation from chemistry to, well, to plumbing.
Plumbing.
Concerta and similar tablets like Relaxin are designed with a shell that is largely intact and non-digestible. It pushes the drug out through a tiny laser-drilled hole.
And the shell itself passes through the body.
Right. And because that shell stays rigid and intact, these formulations should never be used in patients with severe gastrointestinal narrowing conditions.
What would count as a severe narrowing condition?
The sources list things like severe esophageal motility disorders, where the esophagus just struggles to push food down, short gut syndrome, cystic fibrosis.
So for these patients, the pill itself could become a physical blockage.
A mechanical obstruction. It's a serious, potentially life-threatening issue that could end up requiring surgery. It's why patients need to be told that seeing the tablet core in their stool is normal, that's just the empty shell. But if they have these pre-existing GI issues, it's an absolute contraindication.
Wow. A structural physical anatomy issue dictating medication choice. That's something most people just don't think about when they swallow a pill.
Exactly. And it's not the only one. Let's look at the chewable tablets, like Quilichew ER. These carry a distinct choking hazard warning. It's tied to how they absorb fluid. They must be administered with a full glass of water or other fluid, and they're specific. At least 240 milliliters or 8 ounces.
Why the specific volume?
If the patient doesn't drink enough fluid with it, the contents of that chewable tablet can swell up really rapidly and excessively in the throat or the upper esophagus,
Blockage.
causing a physical blockage or a choking incident. It's a simple step, but failing to do it can lead to a severe acute event. It has to have enough fluid to ensure it passes smoothly.
And then we get to the transdermal patch, Daytrana. This introduces a whole new category of risk, environmental risk. I can't believe this is. A hairdryer or an electric blanket could cause an overdose.
It is terrifyingly sensitive. The Daytrana patch works by percutaneous absorption. The drug soaks through the skin, and that rate is dramatically increased by heat.
So the warning is,
The sources issue a crucial, explicit warning. The application site must never be exposed to direct external heat sources. No hairdryers, no heating pads, no electric blankets or heated water beds, even intense sun exposure.
and what happens if it is exposed to heat?
The heat can increase the rate and extent of absorption by more than twofold.
Too cold, so you're effectively causing an immediate overdose.
That's exactly what it is. The patient isn't just getting the drug quicker, they're getting twice the intended dose concentration, all at once.
That is critical information.
And the patch itself requires meticulous handling. You have to alternate the site daily on the hips. If a patch falls off, you have to replace it with a new patch on a different site. And the total wear time for the day can't exceed 9 hours.
And even used patches are dangerous.
They retain a significant amount of residual drug. They have to be folded, adhesive side in, and either flush down a toilet or put in a lidded container immediately to prevent any accidental exposure to kids or pets.
It's a powerful demonstration of how the delivery mechanism itself dictates the entire safety protocol.
It really is.
Okay, finally, we have to talk about the latest update for the youngest patients. UpToDate 2025 highlights a new safety alert for extended release formulations in children under 6.
This is a pivotal change in pediatric practice from July 2025. The FDA now requires expanded labeling that says the use of extended-release stimulants is not recommended in children younger than 6 years of age.
And the evidence behind this is overwhelming.
It is, and it goes right back to pharmacokinetics. You mentioned AUC and Cmax earlier.
Right, can you break those down for a non-clinician? What do they measure?
AUC, or area under the curve, measures the total amount of drug exposure the body gets over a period of time. Cmax is the peak plasma concentration, the absolute highest level the drug reaches in the blood.
And in kids under 6, these numbers were way off.
They were 2 to 3 times higher than in older children who were receiving the exact same dose.
So their smaller bodies just aren't clearing the drug as efficiently. They're basically swimming in far more medication than was ever intended.
That's a good way to put it. And the clinical consequence of that massive spike in exposure was alarming.
The weight loss.
Yes. In one trial, half of the patients in that 4 to under 6 age group experienced such severe weight loss that they dropped by 10 percentiles or more on the CDC growth charts.
That is a massive disruption to normal childhood development.
It's huge. And because of that, Providers are now strongly advised to stop the medication or switch to a lower exposure option, like a carefully titrated immediate release formulation, if they see that kind of adverse weight loss in this very vulnerable group. It just underscores that dosing children is never simple math.
Okay, so we've established that dosing is a minefield, and the formulations themselves carry these strange mechanical risks. But now we have to move to the most serious systemic concern, which is the heart.
Right. And our sources for this, Braunwald's Principles of Cardiology, the EHFS Essential Guidance, and UpToDate, they all speak with an extreme level of caution. This is where the cardiologist's perspective really comes in.
So what's the risk landscape that Braunwald outlines for methylphenidate?
Braunwald basically puts clinicians on high alert. The drug is explicitly associated with severe, sudden adverse events, even when adults are taking standard therapeutic doses.
And the events are?
The reported events include sudden unexplained death, stroke, and myocardial infarction, or MI.
Sudden unexplained death in adults on normal doses. That is an undeniable, chilling risk. What about in kids?
In children, the risk of sudden death has been especially emphasized for those who already have an underlying structural cardiac abnormality or some other serious pre-existing heart condition.
So the drug isn't the sole cause, but it's a potential trigger in a system that's already compromised.
It can be a lethal trigger, yes.
And this means pre-treatment screening has to be meticulous. What steps does a provider have to take before that first pill is even swallowed?
The pre-treatment monitoring has to be thorough. It starts with a detailed medical and family history. You're specifically screening for any history of sudden death, fainting spells, what we call syncope or ventricular arrhythmias in the family. That has to be paired with a complete physical exam to check for any signs of inherent heart disease. And if that history or exam suggests anything is off, then further cardiac evaluation like an electrocardiogram, an ECG, and maybe even an echocardiogram to look at the heart structure is mandatory before you start treatment.
And the EHFS, the European Heart Failure Society, they draw an absolute non-negotiable line in the sand.
They do. Their guidance is crystal clear. For patients with known structural cardiac abnormalities, cardiomyopathy, which is a weakened heart muscle, serious cardiac arrhythmias, coronary artery disease, or any other serious heart disease.
What's the rule?
The use of methylphenidate must be avoided. It's an absolute contraindication. The safety concern is just paramount because these stimulants put an intolerable hemodynamic load on a heart that's already struggling or unstable.
Let's dig into that mechanism of harm. UpToDate details how a drug for focus ends up putting the heart under so much strain.
It acts directly on the sympathetic nervous system. It's essentially putting your heart on a permanent fight-or-flight alert. It elevates your mean heart rate and your systolic blood pressure because it's mediating the sympathetic, central, and peripheral catecholaminergic systems. That surge in free-floating norepinephrine and dopamine acts like a constant internal stress signal.
And that sustained increase in cardiac workload, high heart rate, high blood pressure, that's what leads to these events.
That's the mechanism. It can lead to dangerous arrhythmias or a frank myocardial infarction.
Now, this detail on the onset timing is one of those clinically crucial things we've found in our source material. It separates the immediate stressors from the cumulative ones. Tell us about that timeline.
This is a critical distinction for you to understand. The cardiovascular side effects show up on different timelines.
Okay.
The immediate effects, the rise in heart rate and blood pressure, which can lead to things like arrhythmias and new onset hypertension, those are reported very quickly, often within day 1 to day 7 of starting the drug. That's the heart's immediate reaction to that sympathetic surge.
That makes sense. The heart starts pounding right away.
Exactly. But here's the crucial difference. The risk of a true myocardial infarction, actual heart attack, that risk only appeared to be statistically elevated after 1 week of treatment.
After 1 week.
And it persisted over the next 2 months.
This is huge. It means that while the acute stress response in that first week is obvious, the real deepest risk window for catastrophic damage to the heart muscle opens up after the patient has supposedly stabilized.
Exactly. A standard 7-day follow-up could completely miss the window where the MI risk starts to spike.
It forces a change in how you think about clinical follow-up. Stability after week 1 isn't really an all-clear signal.
Not at all. It just means the patient tolerated the initial catecholamine surge. They are now entering the period of sustained cardiac strain where underlying vulnerabilities can finally manifest as a major ischemic event.
So ongoing monitoring has to be rigorous.
It has to be. You have to measure blood pressure and heart rate at baseline after every single dose increase, and then periodically throughout the entire treatment. And if the patient develops any new symptoms, exertional chest pain, shortness of breath, unexplained fainting, a prompt, immediate cardiac evaluation, including an ECG, is mandatory.
Moving beyond the heart, Harrison's helps us broaden our view to these other systemic and neuropsychiatric complications. It seems pretty clear that, boosting the dopamine system for focus comes with a real risk of destabilizing the rest of the central nervous system.
That's absolutely right. The psychiatric impact can be severe and multifaceted. For patients who already have a history of bipolar disorder, for instance, stimulants can actually precipitate a mixed or a manic episode.
But the risk goes beyond just those with known conditions. What about patients who have never had a psychotic break before?
Harrison's warns that psychotic or manic symptoms, things like acute hallucinations, disorganized thinking, or frank delusional thoughts, have been reported to occur even with usual therapeutic dosages.
In patients with no prior history of psychosis.
In patients with absolutely no prior history of psychotic illness, if those acute symptoms pop up, the drug has to be treated as the likely cause, and getting the patient off methylphenidate should be the primary clinical goal.
And we also see a potential for increased aggression and for making Leydig disorders like Tourette syndrome worse.
Yes, increased aggressive or hostile behavior has been reported. The incidence is usually low, maybe around 2% in some trials. And regarding movement disorders, that dopamine enhancement mechanism means stimulants can absolutely exacerbate both motor and phonic tics.
So you have to screen for that beforehand.
You must. For any patient, especially a child, the sources mandate that a thorough evaluation for the presence of pessarits or a family history of tics or Tourette's should be a routine part of the assessment before you even think about starting therapy.
Now we have to turn to a rare but extremely serious peripheral risk that the sources highlight: priapism. This is a severe urological emergency that needs a detailed warning.
Priapism is a prolonged and painful erection lasting 4 hours or more. It's a critical documented complication of methylphenidate use in both adults and kids.
And this is not just a nuisance side effect.
No, this is a vascular medical emergency. If ischemic priapism isn't treated, it leads to irreversible damage to the penile tissue. You're risking permanent damage, including fibrosis, permanent erectile dysfunction, impotence. It can require immediate surgical intervention to restore blood flow.
And the timing of this is very unusual. It's often linked to changes in the treatment plan, not just from being on the drug itself.
That's the most alarming detail. It can happen after a dosage increase, which you'd sort of expect for a side effect. But it has also been reported during temporary interruptions in therapy, like during planned drug holidays on weekends or over the summer, or even after the medication has been completely discontinued.
So stopping the drug is just as risky as starting it from a urological standpoint.
It can be. The theory is that it's related to an alteration of the complex, smooth muscle control system in the penis, which is affected by norepinephrine and dopamine signals.
So what are the key risk factors that providers need to be screening for?
The sources list several key vulnerabilities. Patients with hematological disorders, especially sickle cell disease, are at an increased risk. Other risks are malignancies and a history of perineal trauma.
And other substances can make it worse.
Yes, the risk is compounded by recreational alcohol use and by the use of certain illicit drugs, cocaine, ecstasy, or even specific prescription meds like some antipsychotics, certain antidepressants, and anticoagulants. It requires a really detailed, holistic review of everything the patient is taking.
Okay, finally, let's touch on that persistent concern, especially for children: the impact on appetite and growth. The sources draw a sharp line between the timing of these two effects.
And that timeline distinction is crucial for monitoring. Appetite suppression is an immediate effect. It's a rapid physiological response that can happen within hours of the first dose. Patients just don't feel hungry.
But the growth suppression comes later.
Exactly. The consequence of that, the reduced growth rates and significant weight loss in children, that's delayed. It typically only appears after months of active, sustained treatment. It's related to the cumulative duration of the therapy.
Which means you have to keep monitoring for the entire time they're on it.
Continuous periodic monitoring of height and weight and assessing their overall growth rate against standard growth curves for the entire duration of their childhood therapy.
Medications rarely act in a vacuum, and with methylphenidate, we see several interactions that are classified as absolute avoidance because the results can be lethal.
Yes, and the first is the critical fail-safe rule we see with almost all potent CNS agents, MAO inhibitors.
A non-negotiable contraindication.
Absolutely. Lexicomp is very clear on this. Methylphenidate is contraindicated during therapy with a monoamine oxidase inhibitor, or MAOI, and for a period of 14 days after stopping an MAOI.
And that includes more than just the classic antidepressants, right?
It does. It applies to drugs like phenelzine, but also newer agents that have MAOI activity, like the antibiotic linezolid.
So what's the mechanism of this catastrophic interaction?
Yes.
What does that hypertensive crisis actually look like?
The mechanism is just total system overload. MAOIs stop the breakdown of norepinephrine. Methylphenidate, at the same time, is stopping its reuptake.
So you have a massive unchecked surge of it.
A massive surge. It causes dangerously high, uncontrolled blood pressure, a hypertensive crisis. Clinically, this can present as a severe headache, palpitations, chest pain, profuse sweating, confusion.
And if it's not checked?
It can result in death, a hemorrhagic stroke, a heart attack, or acute renal failure. Meticulous screening for MAOIs, including over-the-counter stuff and supplements, is mandatory.
Okay, the second, and maybe most common toxicological danger for many users is alcohol. Micromedex and UpToDate are explicit about avoiding alcohol because of this phenomenon called dose dumping.
This is a huge warning. It's often classified as risk X, meaning avoid. Alcohol dramatically compromises the sophisticated design of many of these extended release formulations.
It makes the controlled release mechanism fail.
It makes it fail spectacularly. The presence of alcohol significantly increases the rate and extent of the drug's release. This is true for ER capsules like Ritalin LA and Metadate CD, and also for some chewable tablets like Quilichew ER.
The technical data on this is specific and really alarming. Give us the numbers.
The in vitro studies, the lab tests, are a stark warning. When they exposed some capsules, like Ritalin LA, to a 40% alcohol concentration, which is, a standard hard liquor,
Right.
it resulted in up to 98% of the drug being released in the first hour.
98% of the entire day's dose hitting the system in 60 minutes.
Exactly. And for the Quilichew ER tablet, 90% was released in the first 30 minutes.
What does that kind of acute toxicity, that overdose from a massive Cmax, look like for the patient?
The symptoms are those of massive CNS overstimulation. You'd see extreme agitation, uncontrollable tremors, muscle twitching, a rapid, chaotic pulse, severe hypertension, hallucinations, confusion.
It sounds terrifying.
In severe cases, it leads to seizures, coma, hyperthermia, a dangerously high body temperature, circulatory collapse, and potentially death. The intended slow therapeutic release curve is just completely bypassed. It's a life-threatening scenario.
Which is why alcohol must be strictly avoided with these specific formulations.
Absolutely.
And beyond these two major contraindications, there are several other critical interactions. Let's start with blood pressure medications.
Well, since methylphenidate raises blood pressure and heart rate, using it with antihypertensive agents can decrease how effective those blood pressure meds are.
So you need to monitor blood pressure more frequently.
You do. You might need to adjust the dose of the antihypertensive or even switch to a different one. And similarly, combining it with other pressor agents drugs that also raise blood pressure, you just have an additive risk of dangerous hypertension.
And what about interactions within the CNS, especially with serotonin?
Combining methylphenidate with other serotonergic agents, and that includes a lot of common antidepressants and pain meds, carries a high risk of serotonin syndrome.
Which is potentially life-threatening.
It is. It's where the brain has way too much serotonin activity. You see mental status changes like agitation, neuromuscular abnormalities like tremors, and autonomic instability tachycardia, while blood pressure swings, hyperthermia. You have to monitor closely for those signs.
And even common endocrine medications can play a role in toxicity.
Thyroid products, specifically. They can significantly exacerbate the adverse effects of methylphenidate on the cardiovascular system. The combined stimulant effect increases the risk of hypertension, tachycardia, and coronary insufficiency, especially in patients who already have coronary artery disease.
It's just too much for the heart to handle.
It's too intense.
Finally, we noted that common GI drugs, things like H2 blockers or PPIs like omeprazole, can actually interfere with the release of specific ER formulations.
This goes right back to the physical chemistry of the pill. The gastric environment, how acidic your stomach is crucial for controlling the release profile of these complex systems.
And PPIs make the stomach less acidic.
Right, they increase the gastric pH. And if a specific ER formulation, like Cotempla XR-ODT, relies on a low pH to control its release, changing the acidity can completely alter the pharmacokinetics.
So the pill might release too much, too fast, or maybe too little, too slowly. It messes up the whole design.
It compromises the fundamental delivery design. For Cotempla XR-ODT specifically, the manufacturer explicitly states that using H2 antagonists or PPIs is not recommended. It just shows how exquisitely sensitive these highly engineered systems are.
Despite this, this very lengthy list of profound cautions and risks, from mechanical blockage to dose dumping UpToDate, confirms that methylphenidate is still a cornerstone of treatment.
It is. Stimulants are still confirmed as the most effective and commonly used first-line drugs for managing ADHD across all ages.
But it's typically used as part of a bigger plan.
A comprehensive, multimodal treatment program, one that includes behavioral and psychosocial interventions. The efficacy, when it's properly monitored and managed, is just transformative for so many patients.
And that efficacy is why we invest so much time in understanding all these safety guardrails.
Exactly. And the drug's utility actually extends beyond ADHD because of its fundamental mechanism of enhancing alertness and fighting central fatigue.
Right. The sources note 2 established off-label uses that are supported by Level B evidence. So, strong scientific evidence. What are they?
The first is for treating severe fatigue. This is often used specifically in the context of cancer-related fatigue or in palliative care.
Where the goal is improving quality of life.
Precisely. Improving functional capacity for their limited remaining time. And because these patients are often medically complex and elderly, the dosing starts very low, typically 5 milligrams once or twice a day, up to a modest maximum of 40 milligrams per day.
And the second use is for mood regulation, often in frail populations.
That's right. For major depressive disorder, or MDD, specifically in medically ill or elderly patients, it can serve 2 roles there.
Okay.
It can be used as monotherapy if the patient has a short life expectancy and can't wait weeks for traditional antidepressant to kick in. Or, more commonly, it's used as an adjunct to a standard antidepressant to potentially accelerate the clinical response.
Especially in older patients struggling with apathy and low energy.
Exactly. And again, dosing starts conservatively low, maybe 2.5 to 5 milligrams, but can be carefully titrated up to 40 or even 60 milligrams per day in some cases to get the optimal response. It really reflects that need for high-stakes, individualized titration.
Okay, we've covered the engine, the risks, the dosing minefield, the interactions. Let's try to synthesize all this into a final, actionable monitoring summary for our listeners. Based on this consensus of caution from our consortium, what are the mandatory safety checkpoints?
We really have to consolidate the monitoring across 4 critical domains just to make sure nothing gets missed: heart, mind, and the physical body.
Okay, what's first?
First, cardiac monitoring. This means a baseline, full cardiac evaluation before you even start, detailed family history, a physical exam, and an ECG if it's indicated.
And then during treatment?
Once treatment begins, blood pressure and heart rate have to be monitored periodically, especially after every dose increase. And immediately if the patient reports any cardiac symptoms like chest pain, palpitations, or fainting.
Okay, second domain.
Second, growth and weight. For children, you have to monitor height, weight, and their overall growth rate against the standard curves. That's essential because growth suppression only shows up after months of treatment. And for adults, you still monitor weight periodically because of that immediate appetite suppression.
Makes sense. Third.
Third is neuropsychiatric monitoring. Clinicians have to assess and reassess the risk of abuse and misuse continuously throughout the entire treatment. And crucially, you have to be looking for any new onset or worsening of sics, seizures, new psychotic or manic symptoms like hallucinations or aggressive behaviors.
And if priapism is reported, that's an immediate intervention.
Immediate intervention and discontinuation has to be considered.
And the fourth domain.
Fourth is special populations and formulations. You have to strictly adhere to that latest FDA alert. Avoid ER formulations in kids under 6 because of the high systemic exposure and severe weight loss risk. And for women who are pregnant or planning to be, while the data isn't definitive, the conservative suggestion is to get a fetal echocardiogram between 18 and 22 weeks to carefully check for potential cardiac malformations, given the drug's known cardiovascular impact.
So this drug, methylphenidate, it is effective, but it is undeniably a tightrope walk. It requires not just precise pharmacological understanding, but an awareness of the physical chemistry of the pill itself.
And continuous physiological vigilance across multiple, often hidden systems. It's a drug where the complexity of the delivery mechanism really does rival the complexity of its biological action.
It's incredible.
It is, and we have these detailed sources that give us this granular understanding of the physiological response, and you just can't overstate the clinical implications of that detail. The difference between an immediate side effect and a slow-building cumulative toxicity is the difference between safe management and a catastrophic outcome.
And that leads us directly to our final provocative thought for you to consider. Something to mull over as you process everything from this deep dive. We know from that timeline analysis that the acute stress events, arrhythmias, hypertension, they can happen within day 1 to day 7.
The immediate surge.
But the severe increased risk of a myocardial infarction only appears statistically elevated after week 1, and it persists for the next 2 months.
That timeline tells a story about 2 different types of cardiac stress, the immediate surge and the cumulative strain.
So given that standard clinical practice often mandates a follow-up visit after just 7 days, how should this granular data change that traditional approach? Does stability after the first week actually mean the patient is safe?
Or is it merely the entry point into the deeper, slower-burning cardiac risk window?
It forces us to redefine what periodic monitoring really means, in both the acute and the chronic phases of treatment.
That question highlights the critical need to view this potent medication not just as a quick fix for focus, but as a systemic intervention that requires continuous, tailored vigilance well beyond that initial adjustment period.
Something to think about as you navigate these complex pharmacological landscapes. Thank you for joining us for this deep dive.
Until next time.